All right, in this chapter, we're going to go over chapter 6, principles of lifting, moving, and positioning patients. So here's our education disclosure statement. Viewer discretion is advised. In some slides, they may have visual effects that aren't always suitable for all audiences. We use the Emergency Medical Responder First on Scene 11th edition for our Emergency and Medical Responder course. We do not get paid to use this book. However, over the years, this course has been what has been easiest for our students to comprehend. Therefore, that is why we utilize it. This is work protected by the United States copyright laws and is provided solely for the use of our instructors to teach courses and assess the students' learning process. The content on this website has been made available to our instructors to copy and distribute to our students in classes as we see necessary. All education provided is a guideline to help you learn new concepts to better treat your patient. Your local protocols supersede any education you learned in this course. You must always review with your medical director before changing your treatment plans that are outside of your local protocols. All right, here's some of the objectives that we are going to be reviewing. All right, in this section, we're going to talk about the principles of moving patients safely. So your body mechanics is very important when you're lifting and moving patients. So proper and efficient use of your body to facilitate lifting and moving is first and foremost, you need to make a plan. You need to estimate that patient's weight and consider your physical limitations, your partners, everybody else that's around, and communicate. Okay, communication is key in not getting injured. At the next point, you're going to position your feet properly. So that means your feet should be widthwise as your shoulders, and you should be lifting with your legs. When lifting an object with one hand, you need to avoid leaning to either side. You need to minimize twisting during the lift and keep the weight as close to your body as possible. If you do have a stair chair available, use that stair chair um, when you have that available to you. So as you can see here, her feet are spread with shoulder widthwise apart. She's bending at the knee. She's not bending over at the waist and gonna potentially have back injury. She's going straight up and now she can move. When using a stair chair, you're going to have one person at the top, one person at the feet, and then you're going to have your spotter. Especially in these Minnesota winters with the ice all over the steps and whatnot, that could be a very dangerous situation for not only you, but your partner, and more so the patient at that point. Only move the patient when absolutely necessary. So meaning a dangerous environment. What type of a dangerous environment would you have to move them in? House fire, motor vehicle that's on fire, something is unstable and you need to get them out of there. If they cannot adequately assess their airway breathing and circulation, or if they're significantly bleeding. If you're unable to gain access to another patient who needs life-saving care as well. So this could potentially be in like a motor vehicle accident where you're unable to gain access to the patient who is breathing, but maybe there's a deceased patient in the way. You need to utilize that. You need to move that person so you can access another one. Little protection for patient injury. So in a situation where you have to move a patient, there's not a lot of protection for them. So you have to be very careful, but yet in an emergent move, you're going to do rapid extrication. And just remember that moving any patient could potentially cause them pain. So you have to be extra careful with that. Why is it important to use proper lifting and moving techniques? Well, think about this. You and your partner respond to a third-story building to find a patient who is unable to ambulate due to extreme abdominal pain. How will you safely extricate that patient? So this is something that I want you to think about as you're going through this education, and think about that for the skills portion of this course. All right, the next section is going to be emergent moves. An emergent move is also called an emergency move. So when the scene is hazardous, that's considered an emergent move. When the patient requires immediate repositioning, maybe their airway is blocked and you have to reposition them, or when you must reach another patient who requires life-saving care. Next one is drags. Patient pulled by their clothing, feet, shoulders, or by using a blanket. So you're going to initiate from the shoulders by pulling along the long axis of the body. Avoid dragging the patient sideways. That could potentially cause a spinal injury or of some sort. And then to move the patient down the stairs or down an incline, grab underneath the shoulders, pull the head first as you walk backwards. So think about it from this sense. If you grab them by the shoulders and you let their feet bounce on the stairs, that is how you want it to be. You don't want to grab them from the feet and let their head bounce on the stairs. You're going to cause more problems, right? So again, shoulders, grab behind their shoulders and let their feet drag. Okay, so this is what they're calling a drag. Okay, you have them by their shoulders and you're pulling them backwards. It could be by the clothing, it could be by the blanket. You could wrap underneath their armpits like this here one and just pull backwards. Okay. If you have straps, this is a good one because you can actually be standing up a little bit higher and using a more of your waist and your legs to pull. Okay. So what type of situations might warrant use for an emergent move? Okay. One, EMS should not be going into a house fire, but if the patient is right at the door and there's not a lot of smoke inhalation or a lot of smoke or whatever right at the doorway, you can attempt to, but again, remember your safety is always first. It could be a situation where there's rubble that has fallen over and you have to get that patient away from them before they get buried. Again, always be thinking about your safety first. What further injury might result if the EMRs improperly move these patients? Well, head, neck, spine injuries. There might be a laceration that you haven't seen because you're trying to move them emergently. So there's a lot of different things you have to think about before you move them. Motor vehicle accident. They're tossed out of the vehicle. They're ejected from the vehicle and they're sitting upright in the ditch. Now, all of a sudden, they're talking about they're fine, they're fine, they're fine. But you go to lay them down, and pretty soon you see significant amounts of blood in their groin area. Well, what was happening before that's not happening now? Well, remember, your body can actually be their own tourniquet. So when that patient is sitting upright and they were bent at the legs and bending at the hip area, that was actually maybe potentially closing off that bleed, but now you lay them back and now you've opened up that bleed. So now they're bleeding more. So just think about different things before you move a patient in what situation they were in and what potential injuries they could have. Okay. All right, now you have your standard moves, which is the preferred choice when a situation is not urgent. If the patient's stable and you have time to move them, you should really do these standard moves. You want to use the help of other trained personnel or bystanders, but you want to, again, fully communicate with them what you're doing. So the appropriate reasons for standard moves is patient discomfort, indicated care requires moving them, getting closer to a source of water, and patient insists on being moved. Okay, so these are some reasons. Before moving the patient, you want to complete that primary assessment. Why do you want to complete the primary assessment in these patients? Well, first and foremost, you want to get your baseline vitals. If you don't do an assessment, and like I just talked about with a motor vehicle accident where they were ejected, if you don't do vitals and you don't see what's going on, you may not know that that patient is bleeding. Just same goes for a typical move. You want to do that primary assessment so you have that baseline. Do a head to toe assessment if they're in a trauma type of a situation, just so you know, is there any bleeding? Okay. Don't always think that once you make that assessment that things won't change, because things do change. You have to then decide how many rescuers am I going to need to move this patient. You want to avoid compromising any neck, spine, or back injuries, and then considering splinting the suspected fractures if they happen to have any. So a direct ground lift is one of the lifts that is considered a standard move. There's 3 rescuers that move the patient from the ground to the bed or to the stretcher, whichever you're going to. So the patient is lying face up, which is the supine position. Their arms are placed on their chest. Okay, so you want them placed on the chest so they're not grabbing anything. When a patient grabs for stuff, the one thing that you can potentially have is for them to get you off balance. And so then you could potentially tip over or fall over and then potentially have injury to yourself. So lift the patient up to the level of your knees, roll the patient toward their chest, and then stand together and move the patient. Okay, so here you've got one person under the neck, one patient. If you can see right here, there's a hand right here for this rescuer. There's a hand right here from the female rescuer, and then she's underneath the legs. Okay, at that point, then you're going to bring them up to your knees. Okay, to get them off the ground, plus giving you guys that ability to position yourself, and then the move up. Okay, and then right onto the bed. The next one is an extremity lift, which is a two rescuer. It's one person lifting the patient's arms and the other one, or I'm sorry, not patient, one rescuer lifting the patient's arms and one lifting the patient's legs. This is the ideal moving. It's ideal for moving the patient from the ground to a chair, the stretcher, but do not perform this lift if you have any neck, head, spine, shoulder, hip, or knee injuries or suspected fractures to any extremities as well. So the patient should be supine with the knees flexed. You're going to kneel at the head of the patient, placing the hands under the shoulders, and have the helper stand at the patient's feet and grasp his or her wrists. Okay, so you got one grasping the wrist. Now, remember, this is not for a trauma patient. Okay, so you got the one grabbing the wrist, the other behind them. You're going to slip your arms under the patient's armpits and grasp their wrists. The reason for that is so that that patient, again, doesn't grab anything, but it's also got a good grip for yourself. And then pull them into a sitting position. Okay, so at the count of three, I always do count of three, but you can do five or whatever you decide on. Communicate that information beforehand. On the count of three, you're both going to stand up at the same time. You're going to move as a unit when carrying that patient, and you're going to avoid swinging. If you start swinging or start twisting, that's when injury could potentially occur. Okay, so you're going to lift them straight up. This works well for a smaller patient. When you get to a larger patient, this might not work as well. Then you have the direct carry method. It's when you move a patient with no suspected spinal injury from bed to another bed position or to the stretcher. So you're going to position the stretcher perpendicular to the bed with the head end of the stretcher at the foot of the bed. So it's literally a direct carry move. Okay. All right, so you're on there. There, as you can see, bedrooms, they don't typically have a whole lot of room for you to be able to get the stretcher right in alongside the bed. Okay, so you've got the patients under there. Now, another option would be to use the sheet, but they decided not to. So you're going to roll them up and toward your body and then place them down onto the bed or the cot. Then the next one is the draw sheet method, which this one to me seems to be the easiest in all of these, just because you have more options for more people to be involved. Plus you have a little bit more ability for I don't know, more stability, I think. From side of the bed, you're going to loosen the bottom of the sheet under the patient, position the stretcher next to the bed, adjust the height of the stretcher to match the level of the bed, lower the rails, because remember, cots have rails, so you want to lower that so you're not going up and over that, and then unbuckle the straps. You're going to grasp that sheet firmly at the patient's head, chest, hips, and knees. Draw that patient into the stretcher, sliding in one slow, smooth motion. You can also use the slider board or slide bags if you happen to have them. Anything to help prevent any injury is the best possible method. Okay, so as you can see here, you got you kind of roll that sheet up on each edge just to give yourself a little bit of a grip, and then you can pull. The other side of this is if this happens to be a larger patient, you can have another rescuer at the feet, you can have another rescuer at the knees, you can have another rescuer up at the head, and you're all moving as one unit. And that's what we're going to talk about a lot of the times when we're talking about lifting and moving patients, is it's all going to go as a unit. You're not going to be pushing over the feet and then coming up to the waist and then going to the head. It's going to be all at one time. These little slider boards work really, really good. So that, as you can see, this white one on the side, it's a harder board, whereas the yellow one on the right, that one is a slider sheet. It's a slip sheet. So essentially what'll happen is once you get a sheet up to that point, it'll just slide right on. Just like the white one, once you get the under the sheet, you can just pull the sheet and it'll slide. Okay, so what are the key components of a safe lift? One, first and foremost, communication. Okay, communication is key. If you respond to a home of a morbidly obese patient in no apparent distress, what resources do you have if you find that you're unable to move that patient while using the standard resources? Well, there's a lot of options that you can use. First, you can call in more help. If you're in a rural area, you always have the fire department that you can contact. So you can always call them. But what other things do you have? Is a sheet going to work for you? Do you need to have a backboard? Is that backboard going to be adequate enough to get up and around stairs if you happen to be up or downstairs? So there's a lot of things to think about. But key is make sure you are communicating. I can't stress that enough. All right, in this section, we're going to talk about equipment for transporting patients. So you've got the wheeled stretcher, which is your gurney or cot. Some people call it the pram. It's used to transport the patient from the scene of an emergency to ambulance, and then from the ambulance to the hospital bed. And then it's going to lock into the ambulance, and then the foot and head may be elevated. So if you have a patient in shock, all what you got to do is elevate the feet. If you have a patient who does not want to lay completely flat, you can lift the head of the bed. Okay. So there's different types of wheeled stretchers. There's a single operator, which is the undercarriage that collapses the wheels, and then it goes right into the ambulance. The dual operator, which is the second provider, lifts the undercarriage. So you've got, you put the cot into the truck, the one responder lifts the foot end of the bed, and then they pull these handles, and then another responder lifts the legs up. Or you've got your electric one. And this is what we're starting to see a lot more in the area, is the electric pneumatic lift. It's an electric mechanism that actually lifts the undercarriage for you. So you have more ability to have two people at the foot, and again, hopefully causing less injury to the responders. Okay. So here's what the first one was, where you put the head of the bed in to the back of the ambulance, and then you just push it, and those legs automatically collapse. There's a button you push, and they collapse in. Then this is the one where it's the dual responder, where you have the one person at the foot of the bed, and then the other one is actually having to manually lift up those legs. There's still a lot of these cots around, but hopefully a lot of services are getting to the electric powered one, where you can actually have a responder on this side, on the right side or the left side here, and you can have a responder on the right side. And then you're using that to actually lift and get the cot into the truck. Additional equipment that some departments have is a scoop stretcher, which is good for hip and pelvic injuries, because you can completely pull the scoop stretcher apart, and you can do exactly what it says. You can scoop them up, clip the board back together, and lift and move them. Then you've got the portable stretcher, which is a lightweight and easier to carry down the stairs, and the flexible stretcher, which is restricted or helps in narrow areas. You have the basket stretcher, which is for wilderness or cliff rescues, and then the stair chair, which is the wheelchair for moving patients down the stairs or in tight spots. Okay, so this here is the scoop stretcher. So as you can see up at the top, it pops apart, and it also pops apart at the bottom. One problem with this is right here in the middle. Okay, that is a huge pinch point. So if you have a larger patient, you want to maybe put them underneath the sheet. You can have somebody lift the sheet a tad bit. Great. If not, just make sure you're keeping this in mind, that is a pinch point. Okay, and then you can strap them down on it, and you can lift and put them right onto your cot. Okay, then you got this here one. As you can see, it looks like it folds in half in the middle. But make sure that it's before you put a patient on there, make sure that everything is attached and it's locked so you don't drop them. This is another one that's getting pretty popular is it's more of a flexible one. So this is the one for going around. Hold on. Seriously, Remy? All right. Sorry about that. All right. Okay. This is the wilderness basket. This is what you'll see on fire departments that they'll use. Another stretcher or a backboard. Okay, so all of these are spinal precautions, equipment, spine boards. It's for suspected spinal injuries. You have the vest type, extrication device, CAD board, immobilization of a seated patient in a vehicle. Again, this is only to be used if it is a trauma patient that you have time to work with. If it's somebody who needs rapid extrication, do not worry about putting this on. You need to make sure that you get them rapidly extricated. Then you have the full body immobilization device, vacuum splint that conforms to the body, or the PD board, and that is a spine board for children. Okay, so there's the different ones that you'll see. This is the CAD board. Okay, so it's a short spine board. So essentially this goes down, this goes at their waist, this goes at their head, this wraps the head, this part wraps the body. And that is for people either, it used to be used for just motor vehicle crashes or getting them out, but now it's actually being used for patients who are end up falling in their home, and they're in a seated position. This is a really good one to use. All right, then you got patient positioning. So you got the recovery position, which is the patient with no suspected spine injury. You want to place them on their side to help maintain their airway, which is also called the left or the lateral recumbent position. Okay, so your arms up. Put your other arm down and around. And then what you're going to do is put their knee upward. And then you're going to roll them toward you. Okay, that's what's called the recovery position. So as you can see, this arm is up, this arm's bent, this leg is bent, and then their other leg is straight. And that's going to be for a patient who maybe was in cardiac arrest that you get them back. Maybe it's a patient who has respiratory issues and now you're able to roll them onto their side. Maybe it's a seizure patient who just got done having a seizure and they may have vomit in their mouth. This is what we consider the recovery position. Okay, so that's what it will look like. Okay, next you have the Fowler and semi-Fowler's position. It's when the patient is placed fully upright in a seated position, creating a 90-degree angle. And then a semi-Fowler's position is a semi-seated position where the patient reclines at a 45-degree angle. You also have a shock position, which is the elevation of the feet of the spine. The elevation of feet of spine patient 6 to 12 inches. Wow, that was difficult. Used only for patients exhibiting signs of shock but have no evidence of trauma or injury. You have the log roll. This method is used to move the patient with suspected spinal injury from a prone position to a supine position. This one at least has to have 2 rescuers, ideally as 3. If you happen to have more, great, but you have to have 2 to do this one. Okay, so you're going to have somebody holding the head, applying a C-collar if necessary. You're going to place the backboard on their side so that you're ready to pull that toward you. Okay, 4 people, perfect, because you have 1 at the feet, 1 at the hips, 1 at the back, 1 at the head. Okay, and as you can see, that backboard is sitting right behind them. You're going to pull that backboard in and you're going to lay that patient back down on the backboard. And again, as you can see, they're going all as one unit. They're not pushing the feet on first or the head on first or the waist on first. It's all as one. Okay. Here's another option for a log roll. You got people underneath in multiple different areas. You lift them straight up. Somebody places the backboard underneath them and down. Okay, so here's one to think about. You respond to a nursing home where you have an elderly male who is lying supine in bed and having difficulty breathing. Your partner begins getting oxygen equipment ready. What is your next action? Okay, so this is something that we'll talk about in class, but think about that one for the skills day. All right, next is restraining patients. So you need to secure, when securing combative patients, body and extremities to prevent injury to himself or herself or others. So a physical restraint is holding a patient with your hands or legs so they cannot move, whereas a mechanical restraint is applying a device to the patient to restrict movement. Do not ever, never, ever, ever place a patient face down on a cot and strap them to the bed, ever. Okay. This will not go well for you. Patients can die doing that. So don't ever do that. Hard restraints are handcuffs, shackles, plastic zip ties, belly chains. Okay. If you have them in these hard restraints, you have to have the key to unlock them. Once they're in the back of a truck, once they're in the back of an ambulance, those handcuffs have to come off from behind their back. You can cuff them to the bed or to the cot, but they cannot obstruct any way, shape, or form any CPR potential that may need to be done. Okay. Soft restraints are leather or fabric cuffs, cloth straps, rolls of gauze, cravats, sheets, clothing, something that can restrain them, but it doesn't need a key to get them undone. Okay. So as you can see here, they're putting the straps on here, but if they're combative, you can actually take cravats, wrap it around their wrist, and don't wrap it around the handle of the cot, wrap it around the base of the cot. Okay. It just helps with a tad bit of controlling. The nice part about this one is if for whatever reason this patient stops breathing, cut there, you have your full chest wide open to where you can start CPR. Okay. Always, always keep that in mind. Okay, here's another option for a soft restraint, making sure that you're not pushing it too far in to cut their wrists or in this case, their ankles too. Okay, but again, you're strapping it to this portion of the cot, not the handle. All right, secure limbs with the appropriate restraining equipment. Do not secure the patient face down, okay? Not a good thing. Plus, you can potentially have positional asphyxia, which again, we do not want to have. You want to consider administering supplemental oxygen and check the patient's airway, breathing, and circulation. And that's not just one time. If you have them restrained for any reason, you need to be checking that, every 5 minutes or even more if they are having some additional issues. Okay. So don't take your eyes off that patient. You should always be assessing their airway, breathing, and circulation. If you have to restrain the patient, you want to clearly document the reason for restraining them, ensure that the group uses only force required. Okay. You do not use excessive force. You do not use, you're not using excessive force. Please do not do that. Okay. You want to minimize injury risks by taking prior training on available equipment. If you don't know how to use the equipment, you should not be the one putting it on. You want to communicate the plan to your partners and then act immediately. Okay. You do have the right to protect yourself, but you don't have the right to use that excessive force that could potentially harm or injure that patient. Okay. So think about this. You and your partner are on scene with 2 police officers who have responded to the top of a parking garage where a 24-year-old male is climbing to be Superman. He threatens to jump off the garage and refuses to listen to reason. How do you proceed? Okay. One, if you're going to rush that person, if you're going to run toward them, they're probably going to get freaked out and they're going to jump. Talking to them, telling them to come down, having an open palm, say, let's talk about this, but think about it because we will discuss this in the skills day. All right, so we have learned critical to understand and apply proper body mechanics when lifting either patients or objects. When lifting, you want to always keep your weight as close to your body as possible. Avoid leaning or twisting. Use your leg muscles to lift the weight off. When two or more responders are preparing to move a patient, eye contact and effective communication are very important. Sometimes it's necessary to move a patient, or sometimes it's necessary for a patient to be moved from the immediate area for safety of care. You need to recover in the recovery position. It is effective to care for an unresponsive patient's airway when a spine injury is not suspected. You're going to lift and slide log roll techniques used to position or transition the patient. For uncooperative patients, only use force necessary to apply proper restraints and never restrain a patient in a prone position. Okay. All right. Review questions we're going to talk about in the next class that we have in person. So we will see you then. Here are some questions that you can think about between now and then. All right. Have a great day. Thank you.